So it's terrific to see everyone and to see the progress in this arena. I remember in 1982, or 83, I was starting a fellowship in clinical nutrition and preventive medicine at the Mayo Clinic, and I was spending a lot of time in the stacks there reading the papers on animal models as well as the early studies on population, and thought this is really interesting because cancer is a metabolic disease and we need to really build this space. And presenting this to the first time to the physicians in the preventive medicine department, and they said, this is nonsense. So, you know, we have come a long way at building the evidence base to really try to understand where these associations are and what the mechanisms are. This next session is going to now delve more deeply in what we understand in terms of those areas where we have the data on efficacy as to how we can move forward and really understand what components are most effective at helping people achieve these areas of behavior change and how they can be incorporated as part of clinical practice. So our first speaker, and we have two sections for this next session. The first two speakers are addressing these issues in the domain of cancer patients in specific. And the next two speakers will be talking about the lessons learned more broadly in the area of moving forward with weight loss and physical activity interventions. So our first speaker in this area is Cynthia Thomson from the University of Arizona Cancer Center.
So this is my plug for the meeting being in Tucson where it's 80 degrees today. Thank you. So I want to first start out, I was asked to talk about the effectiveness of these trials, and I always when I think about effectiveness, I always think of my students and what's the difference between efficacy and effectiveness. So I thought I'd quickly put that up there and just let you know that a lot of what we're doing is efficacy, and we are starting to move into effectiveness, and hopefully we'll do more of that work as we go forward. And what I'm going to do today is really talk about how do we make for an effective intervention, and really hit on some of the components that I think we could do better, as well as provide some of the evidence of what we have done well in these targeted areas from the team through the intervention, and then close with some future directions that may be helpful to us as we advance this conversation. So when we think about the teams that are doing these weight loss interventions in cancer survivors, you know, we really haven't said, oh, the studies that put a dietitian against an exercise scientist are better than, you know, the studies that change it up some other way. And I don't think we need to go there. But I do think it's important to drive home that the studies that work in terms of weight loss generally and in terms of cancer survivorship include behavioral scientists, include biostatisticians, include clinicians such as dietitians and exercise physiologists. But more and more we're seeing work that's being done and evidence to support health coaches at a variety of different levels of training, including our nursing colleagues and our public health colleagues working in this realm. We also need to pay more attention and think about health economists, because we know that the cost of what we're doing is an important outcome that we want to assess. Certainly our oncologists and our cancer therapists are important players. And I really want to drive home the importance of survivors. And I know that one of the real joys of working in the cooperative group trial that I'm working in is that every single meeting have survivors there. They are there supporting everything we're doing along the way and giving us their feedback as well. In addition, when we look at the community-based work, we're seeing more and more efforts to engage promotorists as well as the industry-related partners and the programming like the YMCA. I would suggest that one of the things I've learned over time is that as we advance, particularly in the digital world, we need to really engage survival or software engineers early and actively in what we're doing. And there could be a much larger role for adaptive design specialists in terms of our study designs. So what about the population that we're studying? So we talked earlier about how, a lot of the individuals who come into our trials for weight loss, while they may need to reduce their body weight, many of them are kind of the worried well who are already thinking about physical activity and diet and other health behaviors. And we really need to think about how could we add to the diversity of what we're doing. Many of our trials are in women. And many of them, as was mentioned, are in breast cancer. So how do we expand to get all of the obesity-related cancers? How do we increase the engagement of survivors who really are not highly adherent to lifestyle behaviors, or those who have restrictions in diet or physical activity, as was mentioned by Dr. Irwin earlier? Also, how do we move into engaging those individual survivors who may be on medication, say, for reducing their insulin or improving their lipids? A lot of times we're screening them out of our trials, and perhaps we need to screen them in. Race and ethnical diversity is important, and you're going to hear more about that later in the day. And I would argue that many of our trials are inadequately representing males. We attract females at a much higher rate. And then the ends of the spectrum. I know Wendy has done a lot of work with the advanced stage, but really when you look at the totality of the evidence that we have, we've kind of had very little studies at either end of the age spectrum, and we could do better in that well. And then later you're also going to hear from researchers working in rural populations, which is another active area in terms of population that we need to address. So how do we get greater effectiveness? Well, I would argue that one of the things we have not done adequately is really the formative research. Many times we kind of have in our own minds as clinicians that this is what should be done. And we move forward with programs without doing a lot of quality focus group or in-depth interviews with stakeholders. And so I would just argue that we need to do more of that. Sometimes our grant funding makes that challenging, but I think certainly we learn a lot when we do this type of work in terms of general knowledge and understanding what people's interest is, what recruitment models might work, what we can expect in terms of adherence and barriers and problem solving. Many times right now what we're doing is trying to fix things as we go along once the intervention has started, and while there still will be some of that adaptation, it's important that we get as much upfront information from this formative research. And one of the things that I think for cancer survivors, which is really particularly important, is to think about symptoms. And we've heard about some of those symptoms today, such as fatigue and depression. But when we're doing a diet intervention and physical activity intervention, we also want to think about things like bloating and constipation and diarrhea and flatulence and other intolerances that affect what we may be able to expect in terms of dietary change. And so I share some work that we collected some preliminary data from our ovarian cancer study to kind of look at what are the MDASI core symptoms. And what was amazing to me was how high the prevalence is of symptoms, including the neuropathy, that of course is going to affect the number of steps and the amount of physical activity, sleepiness, depression. All of these things are important. So I think we need to integrate this into our interventions to improve effectiveness. But I also want to point out that there is an analysis from the RENEW trial where they looked at symptoms and they actually showed that despite having symptoms, you can work with patients and you can have a positive impact on weight loss. So it's not that we want to give up, it's just we want to have better awareness. In terms of outcomes, I think, we have pretty good data to show that we can change weight with caloric restriction, that we can improve quality of life, and you've heard a lot of this. We can move those metabolic markers, and that we have less data on progression-free survival, recurrence, etc. On the right here, I'm just sharing with you some data from a pilot study we did, and I think one of the things that Pam pointed out, and I want to just drive home, is that we have a large number of our survivors, even overweight survivors, who are metabolically unhealthy. And in this slide, what we show on the left, 52% had classic metabolic syndrome at the time of enrollment into our weight loss study, and within 6 months we were able to cut that prevalence in half. So I think we know this works. What can we do to improve the rigor and the robustness of our designs? Certainly, we're doing better in terms of objective measures of weight as well as waist circumference. I think we do need to make sure we're getting adjudicated outcomes, particularly when it comes to the comorbidities. We want to combine survival and biomarkers, and that has been eloquently discussed already. We want repeated measures. A lot of times we do at the beginning and at the end, and it would be really nice to have measures throughout the study so we can look at trend analysis. And then, of course, objective measures of diet and physical activity change. And as a nutrition scientist, I think, I'll probably go to my grave beating my head about will we ever get there. Hopefully metabolomics, but we'll see. In terms of outcomes, I think some of the things that could get more attention is really thinking about our subgroup analysis. We saw some subgroup analysis today, and a lot of times it's after the fact. They're not a priori, and we're not statistically powered to look at them. And I really think this could help us a lot, not just in terms of potential introduction of bias, but also really be able to get all we can from the information that we're collecting. And then also was mentioned the genetic predictors and how can we use that in an informative way. I mentioned cost effectiveness. Also, there's only been a few studies that have really done a lot in terms of cancer-associated markers of prognosis, or even prognostic scores like the Glasgow Prognostic Index that we could use to kind of standardize across studies what might be happening in terms of outcomes. And then lastly, we have some interesting data that came out in CEBP last month under Dr. Betty Conant and her research group looking at body composition, really trying to drive home that we need to look beyond this. I think back to when I first started studying in this area and Wendy's kind of seminal paper that said this is what treatment's doing to body composition, and yet we really haven't moved the needle on that area to the point that we could. What about the components of a weight loss intervention for cancer survivors? I think we know that we need diet, physical activity, and behavior modification consistent with the current Managing Overweight and Obesity in Adults guidance that came out in 2013. We also have fairly good data more generally on meal replacement. We have expanding data coming out on sleep hygiene, stress management, and the microbiome. And yet we haven't yet integrated those three into cancer survivorship work in a very large way. So I think we will want to do that. In terms of caloric restriction, it's really, as this slide was shown earlier, so I won't go over it again, but it's really, energy that's important and perhaps not as important what the macronutrient distribution is, although as we get more genetic data, as we get more precision medicine, we may find that there are individuals who would benefit from a more tailored approach. What about our theories and methods? Our effective interventions right now use social cognitive theory and theory of planned behavior and health belief model. I think our nursing colleagues are really working hard to look at, do these behavioral theories need adaptation for cancer survivorship? And we haven't really pushed that as well. So I think that's an area where we will see growth, and that will improve the effectiveness of our studies. We know that self-monitoring and building self-efficacy also are important. And we need to use this information to predict weight loss success among our survivors. Now, in terms of motivational interviewing, I think when we think about effective behavioral interventions, certainly MI has been credited with a significant role in changing behavior. This was a systematic review by Spencer that looked at the role of MI in changing behavior in cancer survivors that certainly showed it was efficacious. It seemed to help with ambivalence. It seemed to help with building self-efficacy. But what's interesting is MI is widely applied in our telephone-based interventions, not so much in our in-clinic unless it's a one-on-one counseling session. So, I think MI is here to stay. It is important how we move this forward in terms of survivorship. One of the things I will mention in our LIVE study that we have learned with MI is that it does not translate quite the same in our Hispanic women. And so right away, I think one of the areas that we've learned is that you cannot necessarily take what works in, non-Hispanic white women very effectively and directly translate it to other ethnic groups or other cultures. What about the timing of the intervention? I think throughout the cancer continuum, we would like to do more work to find out more about what is the best timing. I certainly think we have evidence that in cancer survivors, this teachable moment could exist more so than in the general population. I cite for you a U.S. Health and Retirement study where people who were newly diagnosed with chronic disease actually enter more preventive procedures, but when asked about changing physical activity, did not. And then there's other studies where they've looked at men during active surveillance and did that active surveillance diagnosis and approach and push them to get more physically active or lose weight. No, it did not happen. There has been a study of oncology nursing that suggests that patients are highly receptive to interventions during treatment that target health behaviors. And in fact, we did a preliminary survey in our LIVE study and found a very similar response. But the greater the time since diagnosis predicted less healthy eating behaviors in the analysis by Bluthman. So I think we have a ways to go in terms of understanding timing, but we're learning. What about delivery? I think, I've kind of shown these from left to right. We have done interventions with all of these different approaches. In general, group counseling seems to have more of an effect in one-on-one on weight loss than perhaps telephone, although they're pretty close. And as we get less touch, we get less efficacy. I'm not going to go over this table, thank you, but what I tried to do here was include a slide on different delivery modes and what is the impact. Two things I want you to notice is one, again, largely breast cancer regardless of the delivery mode, and that we get weight loss. With all of these approaches, it depends somewhat on touch. And but when we think about touch, we have to think about burden to the patients. The other thing I would say in terms of the touch is that I learned through my research certainly that sometimes there's unintentional touch, including social media and a lot of information being dispensed out there to your cancer patients and your study participants. But we know that cancer weight management studies do generally have efficacy when they have higher touch and when the intensity is built. That said, most of our studies are relatively short term. What about adherence and retention in weight loss studies? Overall, adherence is pretty much similar, but we do see greater retention in weight loss studies among survivors. They tend to hang in there and really work hard to get through the intervention with us. Approaches to enhance adherence and retention are listed here, certainly consistent with what we see in non-survivor populations, but an important area that we need to think about reporting more in our studies is what are we doing to enhance adherence and retention and share those ideas. Fidelity is another area I just wanted to quickly touch on. I grabbed 10 of our weight loss studies with higher participation and looked at the publications. And what you can see is we may have fidelity, but we are not consistently reporting our fidelity. And so I think this, as researchers, we want to think about this. Word count, of course, always makes it challenging. So where are we and where can we go from here? I think we can promote weight change in survivors. That is well established. And there are a number of methods that can work to make this happen. They've been developed, they've been delivered in a number of ways. The gaps and opportunities remain, and I tried to highlight some of those. But I think probably it's time for us to think about getting more pragmatic, trying to think about how do we not only, on the one hand, push precision healthcare, but on the other hand, get the reach to the individuals who need it most. And then lastly, I just want to put in a plug for primary prevention, because I think as a survivor working in survivorship research, I always remember my mentor, Dave Alberts, who said, you know, we want to save the labor of being sick, because that is not what we want for anyone. And so what can we be doing in terms of young children and trying to work in this area to reduce their risk for cancer in the future? Thank you. A few questions. Yeah. Yes.
Yeah, hi. My name is Suzanne Dixon, and I'm here with the Academy of Nutrition and Dietetics.
Yeah.
I think it's interesting that most of the, you notice me clutching my coffee, I'm from the West Coast.
Trying to stay.
I think one thing we need to think about is the fact that a lot of this won't necessarily translate to other cancer patient populations. I think there's a big issue with intentional versus unintentional weight loss. Metabolically, breast and prostate cancer patients are very, very different from some of the other patients we see. So I think it was a couple of years ago, the ACS came out with guidelines that suggested that modest weight loss in the context of a healthy diet and exercise was okay for cancer patients. And you know, I've worked with physicians who said, see, even ACS says weight loss is okay, and you'll see this head and neck cancer patient, you know, losing 30 pounds, which is not the same thing.
Right.
So I think we have a lot of work to do to figure out metabolically what's going on and make sure that, as Dr. Cornea said, we aren't doing harm in some of these populations.
And I think actually the oncology group at the Academy has done a lot of work to kind of advance this agenda and really bring awareness to that. And I do think we don't always know if the weight is intentional or unintentional. I know that's one thing when we've done analysis, for example, with WHI, it's like what was intentional, what was unintentional, and even a person's perception, right? Because, you know, my sister who just lost 5 pounds with her cancer is excited that she lost weight. So in her mind, it was intentional, but in my mind, it was unintentional. So even having people define what is intentional and unintentional can be challenging.